will ask so many things and give.
This is my talk on improving utilization in the IBanks, the strategies. I do not have any financial interest to disclose. In the last 10 years, if you see from 2003 to 2012, our collection has improved from 14%. Overall percentage increased from 39 to 46%. And we need to go about 50% utilization as per Vision 2020 with the mindset of 100,000 credit lastly in the year 2020. These were the data compilation of top 10 banks. So when we talk about this data, these are all utilizable tissue. So collection is not a good terminology unless we talk about the utilizable cornea. And if you see the all India figure, it varies between 2 to 82%. Ideal utilization should be around 65 to 70%. I am giving some example. The data of our IBank system is grossly incomplete. Like this is the last year data what we received at EBA. If you see the Andhra, it is very difficult to believe that they are doing only 20 descent. Similarly in Karnataka 2 descent. If you see the Delhi they are optical PK, there is no data for optical PK. So if you see that this is West Bengal I have kept, this is only probably our data is there. So this data of 20,000 utilization is grossly incomplete. In my mind, I have searched and I have checked with many telephone and email. Probably it is close to 25,000. Probably. So we need to look at this data, and so it is a request from EBI that all corneal surgeon and mainly the IBanker, they should, now the proforma is right, proforma is available, so you can also segregate your data so that you can have certain mindset that in which way you are going. Then I am giving the example of, this is 2011 data. Not randomly, but those cornea used 400 plus. So if you rank the collection wise, rank is there. If you see the utilization number, it is there. But if you rank the performance wise number, then you see a lot of changes in the performance. I mean the utilization percentage is that IBank's performance. Similarly, if you see in that year, if you see that less than 400 is there. So these are the IBanks. These are all names are there with us, so we have to work for these IBanks. You have such a good collection, but if you see the utilization, the percentage is 2 to 12%. So this is grossly unutilized IBanks are there in different parts of the country. Again, if you see the statistics of the government hospital, this whatever we received in our EBA. So if you see that only this area, Delhi we have nice data, and the percentage utilization is also not that bad. It is good utilization, especially from RP Center and other places. But if you see that RIO, this is Kolkata, 1226, 177, RIO Chennai, 1000 and 300. So this is the report I have received just few days back, that up to December what is happening in our country. So grossly data has not been submitted. Whatever data we have now from some of the IBanks, they are regularly submitting the data. And if you see again the rank, utilization number and percentage utilization, if you see that this total change is there. So these three IBanks are performing well. And if you consider this one, that 11, three are collections are 11, but if you see their utilization, one is 23%, one is 59%, one is 85%. So how to maximize the utilization? So the strategies are there, what we are following, that increase in ACRP, preservation media is one of the important concern, in situ collection, graft coordinator, timely tissue evaluation, increased distribution, increased spectrum of surgery, and processing field asking. And this is the key of all the training. So I am giving the example from our event because this is the major part is from ACRP, that is 80-20. So this was our last, before that, I mean 1997 to 2000, it said that only voluntary collection. And if you say post ACRP, if you see the last 3 years performance. So ACRP also helps in procuring younger tissue, we all know that. Because we are now very selective, we don't go to all disease because our collection is very high. We are much more selective now. If you see that less than 65 years, last 9 years, voluntary only 8.7% or the ACRP 91%. So your utilization automatically will be higher. So naturally our utilization increased from 52 to 84. So another interesting example is Aurobindo Rotary International Eye Bank. They actually started ACRP literally from January 2013. And they have increased their utilization from 46 to 66% within this 9 months. And many eye banks, actually those who are more dependent on ACRP, they are having higher utilization rate. In situ collection, we have seen that the collection part is also good, and naturally the collection versus preservation time, it reduces to 0. So immediately you preserve in a best of media and you transport the media to the eye bank. And whole globe collection, whereas this part is lacking. So eyeball is collecting at the night, it is lying somewhere, somebody is evaluating in the morning, then they are discarding the tissue. I mean not optical quality, and so time lapse may be more than 24 hours in many situations, especially on Saturday night. This is most practical I have seen, it is happening in larger institutes also. The choice of preservative media, like as Radhika was telling that MK media 72 hours, so 48 hours is the, we all prefer. Cortisol it is, but safely we are using it for 10 days. We are now 65% cortisol and 35% MK media. And Optisol GS, and because those are costly, we are not using. Like we have certain policies in our, like ACRP collection, not all corneas are putting it. Like the technicians are, they are trained like evaluating on torchlight, good age, etc., pseudophakic, and they ask the eye bank, where should I put? MK media or cortisol? Okay, put in cortisol. So similarly, or MK media, like we want to reduce the cost also, we might not use it. So case wise, we just decide on that day which eye we will be putting in, MK or cortisol. That actually gives us, so suppose there is a therapy, we do a lot of therapeutic keratoplasty, more than 40% our therapeutic. So we need lot of, so even a therapeutic tissue we put in cortisol. Why? Because we can use it for whole week. MK media, we are giving the better tissue to our patients, so to say. Then timely tissue evaluation, we have seen it is lacking. Sometimes the corneal surgeons are busy in clinic, so they do not have time to go to the eye bank. And especially in the late hours, holiday collection. So eye bank technicians can be training. We are on the process of this, and they are giving the preliminary report that like this tissue is good, this tissue is bad, whatever. So eye bank technician, even in the Western world, eye bank technician do all this job, except that contraindication type of thing, they can be decided. But and also they know the specular well. So they have good reading, slit lamp, and at the same time they have specular report in their hand. So they say that this is a good tissue. So good tissue, so immediately the graft coordinator used to call. So Calibration of specular microscope is very important because we have seen in past with the high lab machine we had a bad calibration, and we used to, because post-operatively when I see like 2400 count I used for dissect, and post-operatively I get a figure of 2500 or 2800. So calibration is important. Suppose 2000 you are not using it for dissect, so you are keeping for other purposes. So that has to be done, periodic specular microscope. Then this is the one important post in our IBAC. There is one important post, cornea graft. This is in-house. So we have a list of recipient. We have the, he sits in the IBAC itself. So he has all the data, and he tried to call the surgeon and the patient. So this is, we follow in our IBAC that 10% free of charge, 15% half price to the patient, the tissue process, whatever it is, 3000 something, and 75%. So you can utilize your tissue better. Even somebody is asking tissue from medical college, we send it free. At least I could show that my tissue has been utilized for a poor patient. Similarly, some other NGO. So this is a policy-wise that some IBAC can take this policy, and also subsidized rate for most of the therapeutic PKs. So tertiary center, basically who are doing in the tertiary center, they have a scope of all this because bad ulcer cases they see every day. So ultimately it is a winning set because you have trainee and fellow. They have also need certain patients to be operated. We know these are bad prognostic cases, but it is a good for fellowship program also. That distribution policy, we know that cornea distribution policies is in work. EBI is working for it, and I have received the feedback that most of the surgeons, they ask for optical quality. They don't ask for therapeutic tissue. That means those who are in the CDS chain, they are doing only optical cornea grafting. But if they take, but they have therapeutic patients. We know that therapeutic patients are more than that. So even some tie up with the medical, like we have tie up with medical college. Like if they want, it's 1:1. So we will take one, you will take one, no charge for you. So that way you can distribute your tissue to the local community or in your state. And training of eye, this is the most important part. So all level of staff should be trained. The correct way is to do CST preparation. That is one of the important vital point for in situ collection, learning specular microscopy technique, learning every aspect of corneal preservation, and always communicate with the medical director or corneal surgeon who is available, whether some tissue is like some debate about contraindication, some issue with contraindication, can immediately contact. We have now very good contraindication list. Then junior fellows, naturally your percentage of utilization will be increased. So sometimes we give not sending back the tissue to the IBAC. This has happened, so we give repeated reminder that you should send. If you are not utilizing it for some reasons, you must send the cornea back to the center because in the state. But if it is interested, like from one IBAC to other state IBAC, they should communicate with their local colleague. If somebody is willing to take it, that must be free of cost. Somebody can take it so that tissue could be utilized properly. And in Palam, I am trying to do this in our state. Junior colleagues in RIUs and medical colleges, because there are less training facilities for them. So we are encouraging them to come our hospital, stay with us, cornea patient, but they have huge backlog. So, and increase the spectrum of keratoplasty surgery. So you have to use all the tissue for all kind of keratoplasty we are practice, not only optical PK, dissect or DAL, but you have taken it. And actually we have a beautiful cornea society. We had that problem. We had discussion of wetland. Our hospital data. So last year we have done, you see the therapeutic keratoplasty, how it is increasing. I mean, every year we used to see a lot of patients and everybody tries to dump their patient in our hospital, and we enjoy this surgery because a lot of fellows and therapeutic peak is not that bad. Sometimes you get very good result with them. So take home message is that each donor eye is precious, maximum utilization is important, and lastly, probably this is the important post which is already there in MDC, I mean Government of India guidelines, that cornea grafting coordinator is very important to have a major role to play. Thank you very much for your patience here.